Hello and welcome in nursing webinar session. Myself Shanti, and we are going to talk and discuss about the very critical topic on liver transplant. It's a types and postoperative care. Dr. Dharmesh Kapoor ji will be here. I think he's busy, and he's our senior consultant hepatologist and liver transplant surgeon. It is a very, we are very excited to have him in this session, in our session. And let me also welcome our nurse manager, the senior nurse from the LICU, which is a liver intensive care unit, Ms. Kezia John. I welcome you, Kezia. And we'll be just discussing until Sir joins us. Yes. So we will be discussing, and you can share the slide, the second slide. So we are just going to talk about the prevalence of liver disease. As you nurses, we all have studied that anytime we discuss any disease, we always discuss right from the prevalence. We should also know what is happening in the country. So CLD is nothing but your chronic liver disease is increasingly becoming a global public health priority. Yes, as you can look at the diagram also there, we have now able to portray the fatty liver and the normal liver, and overall the non-alcoholic fatty liver disease and alcoholic liver disease are emerging as important causes of chronic liver disease in the country. And as Sir joins, we will also like to understand from him. And you can go to the second slide. Yes, Kezia, and you can take the slide and talk about it. We'll just modify in between and we'll see. Yeah.
Good afternoon. First of all, thank you for the opportunity to be the part of this webinar with Dr. Dharmesh Kapoor sir and Shanti ma'am. Myself, Kezia John from Liver ICU, and I am excited to be here today to discuss the topic. At first, we look into the liver, that is the second largest organ after the skin. And the liver consists of two main lobes, as we can see here, that is right and left lobe. And these lobes are connected to a small ducts that connect with the larger ducts to form the common hepatic duct. And also there are two distinct sources that supply the blood to liver, such as hepatic artery and hepatic portal vein. And also we can see the liver has some essential function in our body. That means detoxification, metabolism, production of bile, storage of nutrients, blood filtration, regulation of blood clotting, etc.
So as we all have studied, and you all can look at the image key, these are the very essential anatomy which one nurse should understand. We have got this is the second largest organ, and these are the essential functions. I think the liver takes the most burden, function in the body, and as rightly you said, Kezia, it detoxifies, it metabolizes, and all other essential functions we have. Yes, you can go forward.
Yes. And now we are moving towards the liver transplantation. It is a surgical procedure that removes a liver that no longer function properly and replaces it with a healthy liver from a deceased donor or a portion of a healthy liver from a living donor.
Yeah, as we can see the diagram, as this is how the definition of liver transplant is. I think, Teeth, can you check with Dharmesh sir once?
Yes, ma'am, he's joining in a few minutes.
Yeah. So if, so this is how, the liver transplant definition is. It replaces the deceased or failed liver with a healthy liver from another person. Yes.
Now we are going towards the indication of liver transplant. That means there are so many indications for that. First one is acute hepatic failure and extrahepatic biliary atresia, inborn errors of metabolism such as Wilson's disease, glycostorage disease, and hepatic vein thrombosis. That means Budd-Chiari syndrome, hepatic cellular carcinoma, and cirrhosis. These are the most common indications for the liver transplantation.
Okay, so see, when we talk about the indications and as you must be, receiving a lot of cases, like chronic liver diseases and acute liver failure as well.
Yes.
And we would also understand what are the metabolic diseases when surgery. Yes, get forward again.
And now we are going to discuss about some of the risk factors of liver disease. That means alcohol consumption, viral hepatitis, obesity, and fatty liver, and over the use of over-the-counter medications such as overuse of painkillers, acetaminophen, etc., and poor dietary habits. These are all the major causes for getting the liver disease.
So, Kezia, until sir joins, why don't we just look into the postoperative care?
Yes,
we'll
definitely.
just forward the slides and we will just talk about the postoperative care initially.
Yes, yes.
And then we can just revert back again. Yes. Yeah.
Yeah. So this is the main part of our.
That has come. Just a minute. We can just go to the prevalence, right from the prevalence. Sir, good afternoon, sir.
Yeah, good afternoon. Good afternoon. Sorry for logging in a little late. I was in the OPD.
No problem.
And yeah, we can just quickly recapitulate whatever you've discussed so far.
Yes. And as we would like to again welcome that sir is here with us. It is our privilege and honor to have sir in our webinar, and we would just finish the session. We'll keep it very crisp and short. So we were just understanding the prevalence of liver disease, as we would like to also understand why the CLD is increasingly, becoming a global public health priority. And if you can just see the two causes, which is again emerging as important causes, we would like to understand from your point of view.
So I think as Ms. Kezia must have alluded to, the burden of liver disease in the community as well as on a global canvas is increasing. And I'm sure all of our colleagues who've logged in are aware of the WHO initiative, which is called the Global Burden of Disease. So various chronic diseases, non-communicable diseases are covered under the ambit of Global Burden of Disease initiative. And the recent guidance on at least the presence of chronic liver disease / cirrhosis has suggested that the numbers are increasing. And if we were to compare the data from just before the turn of this century to the last 14 or 15 years, there has been an increase of at least 45% in the global burden of chronic liver diseases / cirrhosis. So whenever we talk about chronic liver disease, this is a kind of an umbrella term, and we are talking of both chronic hepatitis, which means that the liver has some degree of scar tissue or fibrosis, and cirrhosis. Cirrhosis means that there is now a kind of a permanent scar tissue in the liver along with the nodular pattern of the liver parenchyma. So nodules get formed because the liver is trying in vain to regenerate and have at least some parenchyma on board which could function and subserve the normal physiology of the liver. So in earlier days, the viruses used to rule the roost, and they used to be the commonest causes of liver disease. And amongst them, hepatitis B in the Eastern Hemisphere and hepatitis C in the Western Hemisphere used to be the dominant players. What we have been observing in the last decade and a half is a surge in the number of patients who have what we call as, or now we call as, MASLD. So that is metabolic dysfunction associated steatotic liver disease. So all our colleagues who've logged in should know now that the erstwhile entity NAFLD or NASH is now known by the new terminology, new nomenclature, which is MASLD, MASLD, metabolic dysfunction associated steatotic liver disease. That means you've got fat in the liver, and along with that, there are metabolic perturbations. And these could be in the form of type 2 diabetes, essential hypertension, dyslipidemia. Many of these patients will have elevated waist to hip ratio, and then they would have a systemically inflamed milieu, which is in the form of an elevated, highly sensitive CRP values. So you have fat in the liver, which is picked up on ultrasound, and along with that, you have got 2 or more of these metabolic perturbations, and then you come under the umbrella diagnosis of MASLD. So MASLD has been on the rise, and it's now accounting for almost 30% of all cases that we see in tertiary care centers. What is the prevalence in the community? Because we should all remember that when you are seeing cases in the teaching hospital, that is not the true picture. That's actually, there is a kind of a referral bias to that. Even in the community, it is believed that at least a quarter to a third of people would have some amount of fat in the liver, and 7 to 10% of these will also have some scar tissue. And these numbers rise further, and in some situations double in patients with type 2 diabetes and obesity. That means type 2 diabetes and obesity, you might have 6 out of 10, roughly 60% of the patients having some fat in the liver, and about 15 to 20% of the patients having scar tissue in the liver. So that is the magnitude of the problem that we've been seeing.
Yes.
Now, the other entity that you mentioned in this slide is alcohol use disorder, and that is something which has been there with us for a long time and continues to haunt us. The only thing that has changed in the context of presentation of alcohol use disorder liver disease is that you are seeing younger people. You are seeing people in their 30s and early 40s. And these also happen to be a potent workforce and breadwinners for the family. So that is why this has got huge social implications. So it's extremely important to know that the alcohol use disorder liver disease numbers haven't dwindled. Viruses have come down, MASLD has gone up, and alcohol use disorder related liver disease remains pretty much the same. So it accounts for about a quarter of all cases that we see with cirrhosis. So that is the magnitude of the problem.
So yes, and thank you for providing us the updated information. And Kezia, you can just take over and you can just go to the indication. Yeah, come to the indication slide. Yeah. Yes, you can just talk, and then we will also understand from sir.
Yeah, the indications for liver transplantation, which includes acute hepatic failure, extrahepatic biliary atresia, inborn errors of metabolism such as Wilson's disease, glycogen storage disease, and hepatic vein thrombosis such as Bhattacharya syndrome, hepatic cellular carcinoma, and liver cirrhosis.
So, sir, as you rightly mentioned, these are all the factors which contributes to the liver disease, and also we would like to hear right from little bit about metabolic diseases. What kind of metabolic diseases which contributes, and one should be taking care of the preventing impact.
Right. So Ms. Kezia has very rightly pointed out the various indications for liver transplant. So in the pediatric age group, the commonest indication is extrahepatic biliary atresia. And then you would also see certain disorders of inborn errors of metabolism, which are actually single gene defects. And these could be in the form of glycogen storage disease, galactosemia, tyrosinemia. Another big basket in the pediatric age group are the kids who have got inborn errors of metabolism related to bile salt or bilirubin export or synthesis. And these are the patients who have got Crigler-Najjar syndrome, or if it is on the export side, then we have got what we call as progressive familial intrahepatic cholestasis. So these are the common indications for liver transplant in the pediatric age group. Now, the metabolic disorders which are very relevant in adult population are patients with Wilson's disease. So, this is a disorder of copper overload. And here again, this is a single gene defect, and you have got, this is probably one of the commonest causes, metabolic liver disease, for which you would do a transplant in an adult. So of course, the disorder starts pretty much in childhood, And as we know that there is a spectrum to presentation. They can present as what we call as acute liver failure. These could be patients who have been picked up on screening as well as biochemical assessment and liver biopsy, and then treated with the copper chelation therapy, but still continue to progress. And every now and then we will see patients who have stopped the chelation therapy, and then they go on to develop decompensated liver disease due to Wilson's. So this is again a very important cause in our country. In the Western world, they also see a lot of iron overload syndromes. In our country, iron overload used to be a common occurrence, especially with the use of the utensils in yesteryears, but these numbers have now come down. Coming to the other causes of indications for liver transplant amongst the adults. So like I mentioned, the viruses, hepatitis B and hepatitis C, and we also get a lot of patients from overseas who have got co-infection of B and Delta virus. Then patients who got MASLD related end-stage liver disease, and patients with alcohol use disorder related end-stage liver disease. About 5 to 7% of patients will also have autoimmune chronic liver diseases which are happening because of drug-induced liver injury when it produces its chronic sequelae. And then, like she mentioned about the Budd-Chiari, so there is a sprinkling of other etiologies, and Budd-Chiari is very relevant to our part of the world. So we have commonly seen patients who got either obstruction of the hepatic veins or the inferior vena cava, and they go on to develop chronic liver disease. Now, almost 20 to 25% of patients who undergo transplant would also have HCC. So there could be a patient who's being transplanted just for the HCC, or there could be a patient who's got an underlying decompensated chronic liver disease, but also a liver tumor alongside. So I also see at the top that you've written contraindications. So the contraindications to liver transplant in this day and world, they have become very few and far between. So anyone who's significantly immune compromised, that means, so all of you might be knowing, and if you are all working in transplant units, we do see a handful of patients with retroviral disease undergoing transplants. So if these patients are immune reconstituted, you can transplant them. But if these patients have got very poor CD4 counts, you do not transplant them. Then similarly, patients who are very frail, who are not likely to get a good quality of life even after transplant, we don't transplant them. Patients who got very significant comorbidities, for example, someone has got bad lungs, say due to chronic obstructive pulmonary disease, interstitial lung disease, bad or failed heart. These are the patients in whom you would not do a liver transplant standalone. Very many patients who come to us for transplant have some degree of renal dysfunction. So it's very important to know, because I'm talking of comorbidities, that the timing of transplant should be very astute. You should not be transplanting people in whom this acute kidney injury has taken the shape of chronic kidney disease. If you see patients who got both end-stage liver disease and chronic degree kidney disease, at least CKD 4 or 5, or somebody who's been on dialysis, then these are the patients in whom we would consider a simultaneous liver kidney transplant and not just a liver transplant alone.
Yes. So, sir, if they are not the criteria for the liver transplant, then we always give them some sort of conservative management, I think, in terms of giving them drugs and lifestyle changes, I guess.
Yeah, so I think so. This process of first diagnosing the patient and ascribing a liver disease severity score, assessing the acuity of the liver disease, and up until the time we take them to the operating room for transplant. So this is a very, very crucial phase for every single patient. And every patient, and the dictum is that every patient must earn their transplant. And you should have exhausted all options of medical management before you would say that this patient should be taken up for surgery. So this would need a multidisciplinary approach. At times we will need inputs from, say, interventional radiologists. Somebody's got diuretic refractory ascites, needing tapping again and again, not responsive to diuretic therapy, but other functions are good. So such a patient, obviously you can tide over this crisis by subjecting them to tips. Then similarly, someone who's got a liver cancer, and you know, if they do not have a donor in the family, you would want to downstage the tumor, or you would like to act as a bridge to transplant. So all these things must be factored in before you push a patient for transplant. And of course, almost ubiquitous to the care of every single patient with end-stage liver disease is their nutritional rehabilitation. So you must understand that patients with decompensated chronic liver disease, they have got very poor nutrition. And if you transplant patients who are very frail, very poor muscle mass, they're going to give you a lot of trouble in the post-operative period. So I think these are the key considerations. So electrolytes should be good, creatinine value should be good, they should be maintained, try to build their nutrition up, keep them away from infections, vaccinate them while we are waiting for the transplant to happen. And then it's a wait and watch story. Their surveillance for portal vein thrombosis and HCC must continue while they are on the wait list.
So Kezia, we'll just quickly go through with the initial post-operative nursing care.
Yes.
Yeah.
So now we are going for to look into the initial postoperative care by the ICU nurse. That is very much important after the liver transplant. First one is the ventilator support for the first 12 to 24 hours in order to maintain adequate oxygen saturation and to maintain stable hemodynamic parameter and acid-base balance. And also we should repeat the APG after the extubation of the patient.
Yeah, I think this is
So this is very, very important, and probably the most important part of this particular discussion and conversation. So when the patient gets shifted from the OR, as the nurse who receives this patient in the ITU, first and foremost, you should see once the patient is transported to the bed, from the bed either of the OR or the trolley, whatever might be the situation in your hospital, please make sure that the patient's the way the patient is positioned in the bed, it's to be done with utmost care. This is very, very relevant to patients with acute liver failure who've got cerebral edema, many of them while they go for transplant, that there should be no jerky movements, the neck should be kept straight, So these are very important things. As soon as the patient gets shifted to your ICU bed, have the monitor start giving you signals. So you have to connect the ECG leads, you have to connect the transducers. Most of these patients will have an arterial line, they will have a central venous catheter. So start your baseline measures of the arterial blood pressure, the central venous pressure, very quick glance to the drains, because you do not want that during transportation, suddenly you find that the drains have turned sanguinous. And in that situation, you have to quickly send an alarm to the surgical team and to the ICU doctors. And then look quickly at the catheter, which is the urinary catheter, to see that the urine is looking light. So these are the various things that you would do as this patient is getting shifted. So this is just what we call as eyeballing. Now, once the patient is stable in the bed and you set all your monitors going, somebody should assist you to check the random blood glucose values. You should quickly see that the nasogastric tube is in place, flash the torchlight into the patient's eyes, make sure that the pupils are equal and reacting, quick touch to the extremities to tell you that yes, the extremities are warm and well perfused. So these are things which are worth their weight in gold. Then immediately come down to the infusions that are going on, because many of these patients would be shifted with some pressor support. So make sure that the lines are in place. And simple rule of thumb for the ICU nursing personnel is that you should have only one infusion going through the port wherein the pressure is going. So a very quick look, and you should see that those details have been well adhered to and looked after. And then you can start taking the instructions from the ICU doctor about what would be the IV fluids to be given to a patient, what would be the antimicrobial strategy, how frequently do you need to do the tests on this patient. And you very importantly mentioned the role of blood gas. We do the blood gas almost immediately as soon as the patient is stabilized in his bed, his or her bed, because that is the most important test which would serve as the denominator for the further course of this patient. And in the blood gas, important things to remember are the values of the pH, what is happening to the PCO2 and the PO2. You will get a quick assessment of the lactate and the acid-base status, so the base deficit. So these are the 5 things which you should immediately register. And if you find anything amiss, then whatever you do in the subsequent hours, it should move these things in a positive direction. So that would be a rapid check for the patient as he gets shifted from the OR to your ICU bed.
Yes, very well said. And we also have mentioned all of your points. I think this is all your, very updated protocol which your LICU nurses, follow. And we urge all the learners and viewers also to just stick to this protocol as per your institution policy. And you can just go to the 10th slide, Kezia, yes.
Yes. And also monitoring of electrolytes, glucose and lactate is very much important, as sir said earlier. And electrolytes disturbances may occur because of the administration of diuretics or the immunosuppressant medications and transfusion of citrate-rich blood products, which leads to electrolyte disturbances. And it should be monitored, and if it is reduced, we should maintain it the normal levels to maintain the respiratory muscle weakness as well as alteration of oxygen hemoglobin dissociation.
Yes, wonderful. So I think all units will have their own protocols. So keep the electrolytes range bound. Many of the patients will get transplanted with low sodium values, especially those who've got very advanced decompensated chronic liver disease. These patients, you have to be very careful that the increment in the sodium should be a very slow one. Under no circumstances more than 8 milliequivalents per liter over a 24-hour period, and definitely should not touch the double digits. Keep the potassium values range bound, as also the magnesium. Both of them are very, very important for the functioning of the respiratory system as well as the cardiomyocytes. Try to keep the ionized calcium in a range of 1.01 millimoles or around 4.5 to 5 milligrams per deciliter. Phosphate is a forgotten ion. Please remember that it's very important. Many of these patients have been on diuretics, so they are hypomagnesiemic and hypophosphatemic. But these are very important electrolytes that we should have on our side while this patient is being prepared in the ICU for the very next step, which should be the extubation. So you must make sure that the heart rhythm is in order. There are no rhythm disturbances. If they are, then quickly plug in a 12 lead ECG and show it to your ICU doctor or have a quick consult with the cardiologist. Make sure that while all of these things are happening, you are also very, very closely watching the drains, the hemodynamics, and also the urine output. So that is what is going to decide what kind of fluids that you are going to use. So roughly, we use about 1.5 to 2 mils per kg of balanced salt solutions. Some units still use albumin. Some units also, I am aware, give prophylactic doses of fresh frozen plasma. We don't do that on our unit. So our mainstay of fluid therapy is a balanced salt solution, and I already described how much of it to give. So please remember that the important paradigms of ICU management of post-transplant patient are that as time passes by, you have to be able to achieve a negative fluid balance in every single patient. Of course, that effort has to start right from POD 0. That means the time the patient comes to the ICU. So please remember that more fluid is detrimental to the larger interest and outcome of your patient. Lastly, about the transfusion triggers. So different units will have their own protocols. In our liver intensive care, at least in the first 24 hours, we want to keep the hemoglobin values between 8 to 9. And thereafter, even if the value drops to a value of less than 8, but the drains are clear and the patient has moved his bowels, there is good bowel movement seen on ultrasound, NG aspirate is not great, then even a value between 7 to 8 would be acceptable to us. But at least in the first 48 hours, we try to keep the hemoglobin between 8 and 9. Gone are the days that you want to keep double digits or 10 to 12 gram hemoglobin values. Please remember, this not only saves the transfusion and whatever are the attendant complications to transfusion, but also it's very important that this patient has got an organ from a different human being. And also, if you want to transfuse blood, there are going to be immunological repercussions to that, as also the other issues with transfusion of either pure RBCs or plasma or platelets. So you could have the transfusion associated cardiac issues. You could have TRALI. You could be just transfusing unnecessarily when it is not needed. And then most importantly, anemia is a very, very good way of transporting more oxygen to the tissues. So all of us should be aware that when you have a good hemoglobin value, the oxygen dissociation curve for hemoglobin shifts to the left. So it's very, very important to keep this curve to the right, and a value of 8 to 9 goes a long way in doing that.
Yes. So I think most of the points have been covered, whatever we have prepared, and you can just come to the 11th or 12th slide. I think we are going to talk about the drawbacks. Come to the drawbacks. Yeah. Keep further shifting drains and catheters with its, we have.
Yeah. Also, as Sir said earlier,
We have done. Come to 13.
Yeah. So.
Yeah.
The post-transplant nutrition or diet is important to monitor because administration of IV fluid until the GI tract function returns normally, that is usually between 3 to 5 days, and enteral nutrition is provided as soon as the postoperative ileus resolves, and TPN is indicated if when GI tract is not functioning well. And importantly, important thing is we should administer the patient a low salt diet and high protein diet, and also the patient should avoid certain types of food because the initiation of immunosuppressive medicine lower the body's immunity. And also another important thing is early ambulation to enhance the recovery as well as the postoperative complications such as deep vein thrombosis.
Yeah, you can again further go forward. Yes, go forward 14th and 15th. Yes.
And now we are looking forward to the potential infection risk and escalation, which includes Lyme sepsis and bacterial infections, includes urinary tract infection, infected ascites, pneumonia, biliary anastomosis, leak, intra-abdominal abscess, and we should be monitored it by the signs and symptoms such as fever, tachycardia, tachypnea, pain, redness, increased inflammatory markers in the blood. So, sir, these are the warning signs which, if it all the ICU nurse sees, they should escalate and take the.
So in a nutshell, there are protocols for ERAS now, which is early recovery after surgery, and the same should hold good for even post-transplant setting. So aim is always to get rid of the tubes and the machines as early as possible, but all of this is going to be dependent on the graft function. So you extubate when you've stopped the sedation, acid-base status is good, electrolytes are good, you're on the downtrend of inotropes, lactates are coming down, the Doppler the next morning looks good. Once that has happened and you've extubated the patient quickly, you further come down on the IV fluids, start giving patients clear liquids. If the bowel is on your side, initially it's regimental feeds, and then you can start them on enteral feeds. In our ICU, for most of the patients, we would be shifting them to their rooms so that they can be with the next of their kin, and that goes a long way in preventing ICU delirium. So in our ICU, we would want the patients to be shifted to the room by day 2 or day 3 max. And in most instances, we'll be able to do that. The next important step is to start getting rid of the lines. So first the Foley's comes out, then the central, the arterial catheter, and then the central venous catheter in that order. So try to get rid of the lines ASAP, because the moment you have done that, your patient can also come off the parenteral antimicrobials. So someone who's on an antimicrobial stewardship should be emphasized in the post-transplant care. And this is extremely important because many of these patients have been on prophylactic antibiotics even going into transplant. Always keep a close watch on the drains, the Dopplers, the acid-base status, how the graft is functioning. As we all know, the immunosuppression starts in the operating room. In the first few days, it's mostly the parenteral immunosuppression in the form of methylprednisolone. Some centers use oral prednisone or prednisolone. And then as soon as the renal function is showing signs of improvement, we initiate the calcineurin inhibitors in these patients, and subsequently the antimetabolites in the form of mycophenolate or azathioprine. Always keep a close watch on what is happening to the patient's cognition, the higher mental function, ambulate them first in the bed, then out of the bed, and then they can start circumventing their bed in the room, and then they can come out of the and walk around in the ICU corridor. Their bowel movements should normalize. Slowly, they should go off all IV support, including IV fluids as well as IV medication. And by day 5, the effort should be for the patient to be on all oral medication. So that would be the kind of a utopian care of a post-transplant patient.
So Kezia, yes, we have already covered everything, and this is how patient has been educated. Yes. And just come to the conclusion part, and I think we have to rush again. Yes. Yeah. So we have seen a lot of your podcasts and blogs and a lot of your healthy talks. What is your message about the liver health discipline? We would like to understand from your point, because
So I think most of our colleagues who logged in are from the nursing fraternity, and the most important message for me is that no transplant patient can survive without the help of the nursing personnel. So that is the first and foremost message that must be conveyed, and every doctor, physician, surgeon, anesthetist should be aware of that fact, that the nursing fraternity is the most important pillar of care in a positive outcome for a transplant patient. So very, very simple tricks which I tried to pass on in the last 20-25 minutes. And these should actually become reflex actions for you. It's very important, when you have a sick patient, then you want the most experienced nurse colleague of you to be caring for them. A very, very important role played by our physiotherapy colleagues too, and our nutritionists. So if someone were to ask me that what is the most important trick of getting a transplant patient out with a positive outcome, so I think other than the surgical input which happens all in the operating room, so these three pillars are the ones which are very important. So the nutritionist, the physio, and most importantly the nursing staff. And we are very, very blessed to have excellent nursing personnel in our liver intensive care, and most of the times they are the saviors for our patients. Extremely important is also to recognize quickly a situation which might go out of hand. So a nurse should not just be following blind orders of what the doctor has said. Supposing the doctor wrote in the morning that X amount of immunosuppression has to be given, but while you were caring for the patient, you found that the patient has become tachycardic, the pressures are dropping, or this patient is behaving oddly with respect to his cognitive behavior, then immediately you should reach out to the ICU doctor or the transplant physician or surgeon and express your concern. So a very, very important component of nursing in this particular context is also awareness of the surroundings. So I think we all know that the care of a transplant patient is multidisciplinary. You cannot achieve the kind of goals that you want to achieve for this very sick cohort of patients unless all components of the care are there in place. So my message is, and especially because we are on the eve of the World Liver Day, that we all have to look after our livers well. This message must spread out to the community. But of course, the main course or syllabus for today was how to care for the patients when they are transplanted. And I think Ms. Kezia, with the help of Ms. Shanti, they have done an exceedingly good job in preparing the slides as well as in spelling out the most important issues that our nursing folks should be caring for while the patient is under their care. Thank you very much, and I wish you the very best for your professional and personal endeavors. Thank you.
Thank you very much for your enlightening discussion, and thank you. And thanks to Kezia and all your team. Thanks to already sir has appreciated powerfully to you guys. So keep up the best practice, and we end the discussion. Thank you, sir.